Hello, and welcome to FTD and ALS, a collaborative approach to diagnosis and care. Part of AFTD's Healthcare Professional Educational Webinar Series. My name is Esther Kane, AFTD's Director of Support and Education. Thanks for joining us this afternoon. I just want to mention a couple things before we start. In order to prevent background noise, our entire audience will be muted throughout this webinar. If you find yourself having any technical issues, you can send a message to a member of AFTD staff using Zoom's Q&A function. We will try to address them as best we can. The last 15 minutes or so of this webinar will be devoted to questions and answers. Click on Q&A to submit questions for our presenters. We'll try to answer as many as we can. You don't have to wait until the end of the webinar to submit a question. Whenever a question occurs to you, simply type it into the Q&A box. Additionally, this webinar will be recorded and posted to AFTD's YouTube page for later viewing. Although CEC and CME credits are only available to those of you watching live. I'd like to highlight an AFTD resource designed for healthcare professionals. It's called Partners in FTD Care. Each issue takes a deep dive into a particular disorder or specific aspects of care. Recent issues have focused on transitioning to residential care, the African-American FTD experience, and what families should know and do after getting an FTD diagnosis. There are over 30 issues of Partners in FTD Care available by accessing the web address at the bottom of your screen. For healthcare professionals watching today's webinar live, we are offering continuing education credits and continuing medical educational credits via Rush University. This is part of AFTD's efforts to educate healthcare professionals on FTD and FTD care. Tomorrow, you will receive an email explaining how to apply for your CEC or CME. Please note you have 10 days from the date of the activity to complete the evaluation and claim credit. Since the discovery in 2011 that the C9orf72 gene mutation can cause both FTD and ALS, it has transformed a long-held belief that ALS is purely a movement disorder and that FTD is purely a cognitive or behavioral form of dementia. It is now recognized that the C9orf72 gene is the most common gene causing hereditary FTD, ALS, and ALS with FTD. These findings have led to new ways of looking at both diseases. Today, we will consider FTD-ALS from the perspective of diagnosis, collaborative approaches to care, and the need for us to work together to find a cure. At the conclusion of this webinar, you should be able to recognize hallmark symptoms of FTD and ALS, describe the diagnostic process for FTD and ALS, list the most common approaches to treatment and disease, and recognize the potential of a genetic causation for FTD and ALS and how best to inform families. Now, I'd like to introduce our first presenter. Dr. Mark Aldaev is an assistant professor of neurology at Harvard Medical School at the Massachusetts General Hospital. Dr. Aldaev has expertise in treating anxiety disorders, depression, and non-Alzheimer's dementia, among other conditions. His research involves the use of non-invasive stimulation to modulate intrinsic functional networks. Dr. Aldaev, thank you for joining us. Wonderful. I will see you soon.
Thank you very much, Esther. It's a great pleasure to be here. And I am just going to share my screen here and talk to you about frontotemporal dementia. As Esther alluded to, I'm going to be speaking a little bit more on the FTD side of the FTD ALS spectrum. So I just wanted to go over how we as FTD specialists approach the diagnoses of frontotemporal dementia. So these are my disclosures. So FTD, frontotemporal dementia, is really a syndrome. And to think about that, we have to think about how it presents. So about 60% of the time, FTD presents with behavioral and cognitive symptoms. And then about 40% of the time, give or take, FTD will present predominantly with language symptoms, and there is some crossover between the presentations, between these two presentations. So when it presents predominantly with behavioral or cognitive symptoms, we call it behavioral variant FTD. When it presents predominantly with language symptoms, we call it non-fluent primary progressive aphasia or primary progressive apraxia of speech. And then the other language presentation of FTD is semantic variant PPA. And I put these crosshairs here. I put this sort of overlapping Venn diagram to illustrate that SVPPA really does exist at the intersection of language and behavioral symptoms. You can get behavioral symptoms with non-fluent PPA. You have behavioral symptoms as a hallmark of behavioral variant FTD. And with SVPPA, it tends to be somewhat at the intersection of those two, with predominance of language symptoms. In addition, there are other manifestations of FTD in which the disorder will present usually with language symptoms, but also with atypical Parkinsonism. So there's something called corticobasal degeneration and progressive supranuclear palsy, where patients will either have issues such as axial rigidity, supranuclear palsy, so limited vertical saccades in the case of PSP. In the case of CBD, we'll have unilateral rigidity, alien limb syndrome, and some cortical sensory loss. But it's atypical for these types of patients, the CBD and PSP patients, to present with the whole language and BVFTD syndrome. And then, of course, we get to our topic today, which is FTD and motor neuron disease. And so motor neuron disease intersects, as Esther already alluded to, with a lot of these behavioral symptoms in BVFTD. And there's also a smaller overlap between motor neuron disease and a predominant language presentation. So as you can see, it's pretty complicated. So we've just been talking about the syndromes with which FTD presents. There's also histopathology, which means that if we were to look at someone's brain under a microscope, what changes would we see? What histopathological changes would we see? And these are referred to collectively as frontotemporal lobar degeneration, or FTLD. So there's two main categories of histopathological changes, more or less. And the two main categories are FTLD TDP, which is referring to TAR DNA binding protein 43, as well as FTLD tau. And then there are genetic factors. So there is a gene called the progranulin gene, and loss of function of this gene in a common mutation can cause type A FTLD TDP. There is the gene that Esther referred to, which is the C9orf72, and we'll talk a little bit more about that in just a second, which can give rise to both type A and type B FTLD TDP. And then the third and final category of FTLD TDP is type C, which is very, very strongly associated with semantic variant PPA. Then there is the MAPT mutation, and together I should just mention that these three genetic mutations really form the three major genetic mutations that we look for when we are suspecting someone as having a genetic mutation, as opposed to having a sporadic case of FTD. And some of the other types of FTLD tau are Pick's disease, which is a 3-repeat tauopathy, CBD, which I've already mentioned, and PSP, which are 4-repeat tauopathies. In addition to these three main genes, there are also a host of other genes which typically give rise mostly to BVFTD, and that is fusion sarcoma, CHMP2B, TAR DNA binding protein gene itself, and VCP. So to talk a little bit more about C9, because as Esther said, that is the main genetic driving force between both many forms of BVFTD as well as FTD with motor neuron disease, also known as FTD ALS in many cases. So that can give rise to both of those, and it can give rise to both type A and type B FTLD TDP43 pathology. The C9 gene is on chromosome 9, as the name implies, And it is a hexanucleotide repeat of the introns on this chromosome. It is responsible for about 40% of familial ALS and about 8 to 10% of sporadic ALS. And one of the interesting clinical features of the C9 mutation is that unlike the major manifestations that you see with BV-FTD, this can present with psychosis. So one sort of telltale that you might have a C9 mutation is if one of your patients with BV-FTD or with ALS presents with psychotic features, complex delusional scheme, or auditory or visual hallucinations. So again, Esther alluded to this. We oftentimes think of BV-FTD as being hallmarked by these behavioral symptoms or these cognitive symptoms. And then we think all the way on the other side, we have FTD ALS or FTD motor neuron disease, which is characterized by these motor symptoms. However, between 10 and 15% of FTD patients meet diagnostic criteria for ALS. Between 30 and 75% of ALS patients will exhibit cognitive changes, and up to a half of ALS patients will exhibit behavioral changes. And importantly, the cognitive and behavioral symptoms can occur before, during, or after motor symptoms when someone has FTD with motor neuron disease. So really, the bridge between BV-FTD and motor neuron disease is really a continuum, and many people think that it's just this continuous spectrum, and it's just a matter of the extent to which you have either a pure behavioral and cognitive presentation or a pure motor presentation or somewhere in between. Not everybody believes that. Other people do believe that these conditions have some distinction that are unique to themselves, but certainly there is a lot of overlap, which is the reason that we're having this seminar today. So let's say you have a patient with ALS in your clinic. What are some of the red flags that that person also might have FTD? And so these are very famous BV-FTD criteria that were published about 13 years ago by Katja Reskovsky et al. In Brain. And I just want to go over each of these because they can all be very important and informative. So one of the hallmarks of BV-FTD is socially inappropriate behavior, loss of manners or decorum, or impulsive, rash, or careless actions. So you might have someone doing something which is completely socially unacceptable in public, such as urinating in public. You may have someone making inappropriate romantic or sexual advances to other people. You may have someone encroaching on another person's interpersonal space, acting as though they know them when they haven't, divulging very personal information to other people. And a lot of these symptoms can loosely be traced to the orbitofrontal cortex. There's a lot of work to suggest that the orbital frontal cortex is involved with behavioral inhibition. And so damage to the orbitofrontal cortex can be associated with this sort of classic behavioral disinhibition. Another sort of classic story of behavioral disinhibition is a patient who might be in a restaurant and might literally go over to another table and take food off of that table and start eating it. Another hallmark symptom of BV-FTD is that of apathy and/or inertia. And so this is something that, as many of you know, is very common in a lot of neurodegenerative diseases. It's certainly common in Alzheimer's disease, but this can be the primary presentation of behavioral variant FTD, where people are not necessarily depressed. And one of the important things to disentangle is to basically be able to disambiguate depression causing apathy and inertia versus BV-FTD. And one of the ways to disambiguate those two is that people with depression tend to report, this feelings of sadness, of hopelessness, maybe even suicidal ideation, have this sort of negative bias, whereas people with pure apathy don't report those at all, but they have just lost interest in some of the activities that they usually used to relish. They might socially withdraw from their families. They might speak very, very little, and this is not because they have an actual aphasia, but just they are just not interested in expressing themselves. And this is classically anatomically traced to the medial wall of the prefrontal cortex, such as the anterior cingulate gyrus, as well as the rest of the medial prefrontal cortex. Another hallmark is diminished response to other people's needs and feelings. So it's not at all uncommon for someone with BVFTD to be very cold, to be less related to their loved ones, to even act in a selfish manner, and lose empathy. And so this has been traced anatomically to the temporal pole, as well as to the medial prefrontal cortex, which is oftentimes responsible for sort of deciphering the emotional state of another person, knowing cues that another person is in pain, or knowing cues that another person is upset, or maybe that they're happy, sort of being able to detect the emotions of others. And people with BVFTD have a very, very difficult time doing this, and tend to thus come across as being very distant. In addition, there are often these repetitive movements or complex rituals that people with BVFTD might have. This can be localized to the basal ganglia, as well as basal ganglia thalamic cortical loops. So people with BVFTD might hum in a sort of ritual way. They might do things with their hands repeatedly in a ritual way. They might have stereotypy of speech, such as echolalia, repeating things that other people say. So this is not at all uncommon. And then there are changes in food preferences. So people with BVFTD classically will have an enhanced sweet tooth, where they'll be very, very attracted to sweet foods and have this compulsion to eat a lot of sweets, and oftentimes they'll gain a lot of weight. Another interesting aspect of people with BVFTD is they might not get disgusted by foods that are not, very appealing, and they might consume things that are spoiled or rotten. And so that's very interesting. And if you think anatomically of where these things trace, obviously because of the change in eating, the hypothalamus is implicated, but there's also this strong implication of these interoceptive pathways, which arise from the viscera and travel up in the spinal cord to the thalamus, to involve the hypothalamus as well as the anterior insula, and then travel down the spinal cord back to the viscera. So there is this real deficit that people with BVFTD have in terms of getting a sense of their own internal milieu, of visceral awareness. So people have done things like heartbeat detection tasks in people with BVFTD and shown that people with BVFTD make mistakes with that they might not be able to track the sort of sensations in their GI tract, and so on and so on and so forth. Some other cardinal symptoms that aren't in the Raskowski criteria of BVFTD would include severely diminished insight. So oftentimes patients with BVFTD will come into the office and say, I don't know why I'm here. There's absolutely nothing wrong with me. So of course, this is very common in other neurodegenerative disorders, but it's particularly pronounced in people with BVFTD. And it's actually somewhat uncommon for someone with BVFTD to say, yeah, I understand what my spouse or partner or loved one is saying. I do have these changes in my personality. It's often the case that they will deny it. There's also this very interesting phenomenon of utilization behavior, which was defined by the great neurologist Lermite. And this is this interesting phenomenon where people with BVFTD will sort of be stimulus bound. They will approach items in their environment and use them for their intended purpose. They might see a pair of eyeglasses on a desk and feel the need to pick them up and put them on their face. They might see an envelope and feel the need to, put a piece of mail in it. They might see a toothbrush and just feel the need to pick it up and use it. So that is something that is not too uncommonly seen in BVFTD. In addition to all these behavioral changes, there are changes in cognition, specifically executive dysfunction. So this can be traced to the dorsolateral prefrontal cortex. Oops, sorry, going to head back for just a second here. And we will talk about what those are. People can have deficits in episodic memory, but there is a relative sparing of episodic memory with BVFTD. So In terms of some of the language manifestations, we talked about non-fluent primary progressive aphasia. We also talked about semantic variant primary progressive aphasia. This is an illustration of the language networks in the brain, and these are just the criteria of PPA. But as I said, oftentimes people with BV-FTD will present with either this cognitive syndrome or also a behavioral syndrome, as we've been describing. This is where atrophy or shrinkage tends to occur in BV-FTD. So this is a study that we did showing atrophy, obviously in prefrontal cortex, in medial prefrontal cortex, here dorsally, in the temporal pole. This is another study showing prefrontal atrophy, and this is just a structural scan showing a difference between a normal brain and one that has been affected by BV-FTD. Getting into a little bit into the differences in structural integrity between BV-FTD and ALS. These areas represent portions of the brain that might be atrophied in ALS. These areas represent people who have a C9 mutation, which is giving rise to ALS FTD, to those who have ALS FTD without a C9 mutation, and to those with just BV-FTD. The other thing that we often do in our diagnostic workup of people with FTD is an FDG PET scan. And the FDG PET scan is meant to look at metabolism. And the classic pattern of hypometabolism that we see on FDG PET is this decreased metabolism in the prefrontal cortex, as you can see here, very normal metabolism in the back of the brain and decreased metabolism in the front of the brain. And at MGH, we will often do an FDG PET in conjunction with a structural scan to diagnose our patients with FTD. So some of the neuropsychological testing that can be done, we remember, as I said, that people will have executive deficits with FTD, with BV-FTD. So you could test executive functions such as working memory with an NBAC paradigm, attention and monitoring with a continuous performance task, cognitive flexibility with a Wisconsin card sort, planning and reasoning, Tower of Hanoi and Tower of London tasks, response inhibition with the Stroop and other related tasks. And interestingly, also in their armamentarium, neuropsychologists will sometimes do these social emotional tasks with people with FTD, such as asking them to interpret what someone's mood is just by looking at their eyes, or giving them some kind of scenario where someone does something rude and inappropriate and asking them to judge whether what they did was rude or inappropriate. So this is just the end of the Raskowski criteria for BV-FTD in terms of probable and definite. Once we have the behavioral and the cognitive symptoms of FTD, we need sort of the neuroimaging symptoms to push it into the probable range, and then definite BV-FTD can only come with autopsy. So what are some of the strategies that we can use to mitigate some of the behavioral changes in FTD or in FTD ALS? Agitation can be addressed with Depakote, valproic acid, or other mood stabilizers, or with SSRIs. But I've found personally that significant agitation and psychosis, as you might find in C9 carriers, are really best managed with neuroleptics and atypical antipsychotics such as risperidone, olanzapine, aripiprazole, and so on and so forth. Obsessive symptoms can be really difficult to treat when people become very obsessive and sort of stuck with very limited mental flexibility. You can try high-dose SSRIs such as fluvoxamine. And then there are behavioral ways that you can address some of these symptoms, such as redirection strategies, different devices, such as maybe even putting mittens on someone's hands if they are sort of ritually and habitually biting their nails. And then this is just an example of a sort of codified behavioral approach called the DICE approach, which folks can find online. It's just one of many behavioral approaches that our unit uses in people with BV-FTD. So just wrapping up here, these are the revised strong criteria for FTD ALS. Again, we think of it as being along this continuum. There is sporadic BV-FTD and sporadic ALS. And then, of course, there is the familial BV-FTD and familial ALS. We talked about the C9 mutations, and we'll talk a little bit more about it. There is Of course, the ALS with behavioral impairment, which requires apathy, or 2 Raskowski criteria, with cognitive impairment, which requires executive or language dysfunction, with both cognitive and behavioral impairment. And then to have the diagnosis of ALS, FTD, one really should have ALS plus progressive behavioral and cognitive deterioration. Remember, as I said, that the changes, the cognitive and behavioral changes can occur first and then have motor changes, or you can have motor changes and then cognitive and behavioral changes, and 3 or more Raskowski criteria, or 2 of the criteria, and psychosis or loss of insight or language impairment. So to conclude, BVFTD is a syndrome characterized by cognitive, dysexecutive, and behavioral symptoms. Both are required, really. You can't just have a behavioral syndrome without any cognitive dysfunction. And the same thing, we get a lot of referrals saying, I think this person is BVFTD because they're young and they have executive dysfunction, but absolutely no behavioral changes. And oftentimes those patients turn out to have early onset Alzheimer's disease. The workup includes caregiver history, structural and functional imaging, and neuropsychological testing. There's extensive crossover between FTD and ALS, and the C9 mutation can give rise to both conditions. And clinicians should always be aware of the other condition when they have diagnosed one of the 2. So thank you very much for your time.
Oh, thank you so much, Dr. Eldiet. That was excellent. I learned some new things myself during that presentation. And at this time, I would like to ask Dr. Suma Babu to join me on stage. Dr. Babu is an ALS and neuromuscular neurologist at Massachusetts General Hospital. Her clinical career is focused on improving clinical outcomes for patients with ALS, motor neuron diseases, and neuromuscular diseases. Her clinical research is centered around accelerating treatment and biomarker discoveries for patients with ALS and other motor neuron diseases. Please join me in welcoming Dr. Babu.
Thank you, Esther, and thank you to the organizers for organizing this important webinar that really bridges the 2 fields of ALS and FTD. And in my talk today, I will give a high-level overview of how to recognize ALS symptoms if you are an FTD specialist and what to do as next steps. Let me share my screen. Right, I hope I'm sharing the right screen and you can see the slides. So first of all, when we're thinking about ALS, we want to understand what's the biology of ALS and how does it intersect with the biology of FTD, and why is it important for us to know this? And then we go into the clinical features of ALS and diagnostic workup and what to do next. So from a disease biology standpoint, ALS, amyotrophic lateral sclerosis, is a disorder, neurodegenerative disease that primarily affects muscle strength, and it affects motor neurons. As many of you know, that motor neurons are sort of scattered in the brain as well as in the spinal cord. The ones that are located in the spine are called the lower motor neurons. They're sort of like relay centers, whereas the ones that are located in the brain and the primary motor cortex are called the upper motor neurons. And a patient is diagnosed with ALS if they have a combination of upper and lower motor neuron signs. And we'll talk about what the clinical features are and how it's slightly different for upper and lower motor neuron manifestations shortly. And so this is a cartoon showing the upper motor neuron location and thinking about the precentral gyrus, the primary motor cortex. You zoom into this going back to medical school biology, and where you look at the layer 5, those are the bed cells that are scattered there. Those are the upper motor neurons. And when these degenerate, we have symptoms that are primarily spasticity, pseudobulbar affect, or hyperreflexia. These are the clinical manifestations. And then when you look at the spinal cord as well as the brainstem, where the lower motor neurons are located, when these degenerate, you have symptoms of muscle atrophy, fasciculations, weakness in sort of a muscle group pattern of weakness. And there are several papers that talk about high-yielding muscles, or muscles that have a higher predilection of being affected in ALS. It's not uniform, whether it is an arm or a leg. And there are certain muscles, the distal arm, or the hand muscles, the distal feet muscles, that tend to get more frequently involved. And when you zoom in and look at the microscopic histology, the biology of ALS, it turns out that TDP-43, you heard from Dr. Eldaev, it was a great presentation, that the TARDP binding protein 43 is common in the FTD manifestations. And it turns out that the same protein, TDP-43, mislocalization and aggregation within motor neurons accounts for more than 90% cases of all ALS. The two exceptions where TDP-43 is not seen are two genetic forms of ALS caused by SOD1, superoxide dismutase 1 mutation, or fusion sarcoma or FUS mutation. But in majority of other cases, TDP-43 is the common denominator to think about between ALS and FTD syndromes. And what we know from seminal postmortem studies is that the spread of TDP-43 occurs basically in stages. And this is beautiful work from Brock and Brett Schneider's group talking about stage 1, where it starts in the primary motor cortex. And as the disease continues to spread, the TDP-43 aggregation, mislocalization, the anatomical localization of this starts to spread beyond the motor cortex. And at some point, it starts to involve pretty much multifocal, multi-regions of the brain. And what we also know is that in addition to the protein aggregation, there are other mechanisms that go hand in hand with this. Neuroinflammation, particularly microglial activation or even activated astrocytes, are common. And this has been shown in multiple preclinical models in ALS, where the neuroinflammatory changes, glial activation changes, follow or they're associated with the pattern of TDP-43 spread in the brain as well as the spinal cord. And when you think about the different stages of how the ALS starts in an individual and when it manifests, there is increasingly recognized pre-symptomatic prodromal phase. And there is even a thought that there is a minimal motor latency period where there are some subtle signs, but the full form of atrophy weakness has not manifested itself. So if you're an FTD physician caring for an FTD patient and you're not sure if ALS is developing, subtle signs, including hyperreflexia or early signs of fasciculations, even early signs of muscle bulk asymmetry or atrophy could be heralding manifestations of ALS symptoms beginning in those patients. In early symptomatic ALS, the muscle atrophy and weakness continues to spread in a particular arm or leg or limb or in the bulbar segment, and then it eventually spreads to other regions or spinal segments, and ultimately leading to a fatal end of life event. Now, we heard about the C9orf in terms of the disease biology, and not to repeat what Dr. Eldaev mentioned earlier, so C9orf is another intersection in that Venn diagram between ALS and FTD, and it turns out to be the most common cause for ALS, genetic forms of ALS as well. It runs in families and could also be seen without a family history in many individuals. And we know about the biology of CNS being overly complex, and it makes it more difficult to find disease-modifying therapies for ALS because it's not one single problem. It could be a combination of 3 different problems or maybe more that we don't know about. At least to begin with, we know that there are hexanucleotide repeats, and these can be in the form of a sense or antisense strand, the sense strand being the G4C2 repeats and the antisense strand being the G2C4 repeats. And when these hexanucleotide repeat containing RNAs start accumulating within the motor neurons, it creates toxicity to the motor neurons. There's a second problem that the RNase H, which actually is meant to break down these RNA or degrade the RNA, may be sequestered, and maybe it is not available for optimal degradation of these toxic hexanucleotide containing repeat containing RNAs. And so that creates a second problem in terms of motor neuron toxicity. And there is increasingly recognized a third problem, even though the repeat expansions are occurring in the intronic portion of the particular gene, there is an increasingly recognized haploinsufficiency of the functional C9 protein as such. And so if you target one and not the other mechanisms, you may not be very effective in actually modifying the disease. And that goes to some of the failed trials we've seen in the recent past with C9orf ALS and antisense oligonucleotides targeting C9 as such, which only target maybe the sense or maybe the sense and a little bit of the antisense, but not the full spectrum of all the disease biology. And so the toxicity comes from the repeat containing RNAs. And then when you have breakdown products, these are the dipeptide repeats, those can also be toxic. And depending on where those dipeptide repeats are coming from, whether it's a sense or the antisense strand, there could be many different types of proteins and different types of aggregates that you may see. And to complicate things further in this disease, there is on top of the hexanucleotide repeat, there's also TDP43 aggregates as well. So in addition to whatever is happening at the DNA RNA level, now the downstream pathways in terms of autophagy, mitochondrial dysfunction, neuroinflammation, and the nucleocytoplasmic transport dysfunction, these things can actually be common for many forms of ALS, and it's not unique to C9 particularly. And we tap into some of these common downstream pathways to say that if you're developing therapeutics for ALS, any form of ALS, that applies even to individuals who are suffering from C9 form of ALS, until we figure out a way to genetically modify the upstream pathways, we can still sort of utilize medications that are used, or experimental medications are being tested for all forms of ALS, even in C9 ALS. So how do you recognize ALS clinically? There are a number of symptoms, as I mentioned before. So you have the upper and the lower motor neuron localization. The upper motor neurons, when they're involved, it creates a syndrome of certain findings, including spasticity, not rigidity, but more along the lines of clasp knife pattern of spasticity, and you can grade it. It can, in more severe forms, it could be actually extremely spastic, where you can't move a limb at all. There could be hyperreflexia. And when you're looking at hyperreflexia as a neurologist, particularly for ALS, we think about reflexes that are exaggerated than normal in some of the reflexes that are present even in healthy states. But we also think about pathological reflexes, and that's important in determining whether there is a combined upper and lower motor neuron dysfunction in a particular spinal segment. For example, certain reflexes such as the Hoffman sign or the palmamental reflex or a brisk jaw jerk, or all of these may not be seen in healthy states, but you will, if you see this with a concomitant presence of atrophy and weakness, that should raise a suspicion for ALS being evolving. And then some patients may experience pseudobulbar affect, which we consider as an upper motor neuron sign pertaining to the bulbar segment, as well as a spastic or slow form of dysarthria. Now, lower motor neuron findings, depending on whether it affects the bulbar segment or the spinal cord, may manifest slightly differently. The bulbar segment lower motor neuron manifestations may include flaccid form of dysarthria, more slurring of speech, not so much the slowing. The slowing is more along the lines of spastic dysarthria. And particularly when you ask patients to repeat certain syllables of pas and las and cas and gas, you can identify if there is a labial, lingual, pharyngeal, or guttural form of weakness that is contributing to some of the dysarthria features. In addition, patients may endorse chewing or swallowing difficulties, tongue fasciculations on examination, or atrophy weakness. In addition, people may have sialorrhea, and this can take the form of both thin secretions in the mouth, or it could also be a lot of thick mucus secretions in the throat that patients may complain of. And with that, they may even complain about difficulty with coughing, with a weak cough that indicates more respiratory muscle weakness as well. And facial weakness, very rarely we've seen patients who may have facial diplegia as well, and erroneously may be diagnosed as Bell's palsy when it initially starts, but it could be a manifestation of ALS. When the lower motor neuron dysfunction sets in the spinal segments and affects limbs particularly, you look for patterns of atrophy, fasciculations, and weakness. Weakness is the most important thing. Now, some pictures that are sort of telltale signs of split hand in an ALS patient, primarily involving the thenar aspect or the thumb aspect, half of the hand, that primarily where a patient may lose muscle bulk in the web space between the thumb and the second digit, as well as the muscle at the base of the thumb. These are the FDI and APB muscles preferentially, but sparing the other muscles of the hand. That's called a split hand pattern of atrophy. And then in some cases, very, very rarely, there is a bibrachial form where the disease may remain focal and localized only to the arms and the hands and doesn't spread into the other segments until many, many years later, and tends to be a slower progressing form. So lack of spread early doesn't mean it's not ALS. It could still be ALS, and it could be a very focal form of ALS. Same thing with the leg too. People may experience foot drop, and if you're a neurologist and you examine the foot carefully, you may notice that it's actually a flail foot. There is weakness in all patterns of foot movement, ankle dorsiflexion, plantar flexion, inversion, eversion, and doesn't really conform to a certain mononeuropathy or a nerve root problem as such. And so the drop foot, again, may remain focal in some small percentage of patients without spreading. So if you just see a foot drop and you don't see spread, it doesn't rule out the possibility of ALS. It could still be ALS in the right context, and occasionally it may remain focal for many, many years. Now, if you look at craniobulbar features, there could be marked tongue atrophy, scalloping, fasciculations, and in more advanced cases, there may be restricted tongue movement, both in terms of protrusion as well as lateral movements. They may not be able to bring their tongue into their cheek for tongue-to-cheek anti-resistance testing. People may experience head drop. People can have core weakness as well. And how do we remember all of these different signs and subtle signs of ALS? And if you're an FTD physician or a neurologist, you may see probably very few cases of ALS. And how do you remember the nuances of all of this? To make it easier for non-ALS neurologists, we have created an instrument called as a Think ALS instrument. And this was developed in conjunction with the ALS Association as a part of a time to diagnosis working group, which I've had the privilege of being a part of. And so this primarily walks a neurologist through systematically through both signs and symptoms of ALS, making it really easy for neurologists, particularly maybe general neurologists or non-ALS neurologists, to go through categories A and B, look at the top segment. If you're seeing a patient with asymmetric muscle weakness with no sensory symptoms or radicular pains, and then you look at limb onset features in category A or bulbar onset or features in category B, and if they have at least one feature in either of these, and then if there is another feature in category C, it really increases the suspicion of ALS. The important part is there's a category D in the top panel where we are trying to rule out other possibilities of when it may not be ALS. If there is radicular pain predominantly, and we've mentioned about symmetric proximal or distal limb weakness, it can still happen in ALS, but tends to be the less common phenotype. And this is primarily for that initial screening of a patient if you're suspecting ALS. Cogwheel rigidity, again, goes more in aligned with Parkinsonian disorders, not so much with ALS. We see more spasticity, prominent sensory loss, isolated fasciculations without weakness. The most important part is there weakness in a certain muscle group or muscle? That's the most important symptom and finding to identify on examination. And if if the patient has at least one feature in category A or B and no features in category D, and if they haven't anything in supporting in category C, like a family history of ALS or dementia, or it is unintentional weight loss with muscle weakness, or unexplained neck weakness, unexplained frequent falls and gait abnormalities, or hemidiaphragm weakness or orthopnea. Or, oftentimes when we think of end of day worsening of speech and weakness, we think of myasthenia gravis, but ALS patients in the early stages can also have that fluctuation in the weakness. At the end of the day, symptoms may seem a lot worse. And hyperreflexia in the presence of atrophy and weakness, then it should sort of raise some red flags in terms of we might be dealing with ALS. And if that's the case, we don't have to wait for a patient to meet all the criteria for ALS before referring somebody to a multidisciplinary ALS center or even treating. And this would qualify for an urgent referral to an ALS center. And so there's a QR code on this tool that you can look up the nearest ALS center by zip code, by state. And this is available on a website called thinkals.org that you can easily find, and making it really easy. And if you're still in doubt and you're not entirely sure, it wouldn't hurt at all to just make an outreach to the ALS physician at the nearest center and say, I have this patient, I'm not entirely sure, but I'm worried. Would you be able to take a look? And that's completely appropriate. The important feature, again, is that they should have weakness in addition to the other symptoms. So how do you recognize, we heard from Dr. Eldaev about how to recognize FTD in an ALS patient. Now, the reverse in terms of trying to understand why is it important to recognize cognitive dysfunction or FTD in ALS is important. It is important if an ALS patient is having subtle signs of cognitive behavioral symptoms, all the symptoms that Dr. Eldaev mentioned in terms of BV-FTD, not because that we're worried about, not because we're worried that this is going to affect their ALS care, but because it is partially because it might affect their ALS care, but more so because what we've learned from different studies is presence of FTD symptoms, even if it's not a full-blown FTD, even subtle signs of cognitive behavioral symptoms are associated with very high caregiver burden, as well as lower compliance with ALS therapy and care plan, in addition to several other complications. When you ask patients, ALS patients, on their self-reported quality of life scales in terms of whether these cognitive behavioral symptoms have had any influence on themselves, there was one study that showed that it actually did not have any influence on themselves unless there was a coexisting depression or more advanced disease. But the non-compliance with or making a decision about a gastrostomy, PEG, or use of non-invasive ventilation was much higher. And one study showed that survival was shorter by about 11 months in patients who had frontal lobe dysfunction, ALS. And so we tend to use in ALS clinics, ALS Cognitive Behavioral Scale as a routine screening questionnaire to look for signs of FTD. There are two components to it. The cognitive component is the one that patient fills out, and the behavioral component is the one that the caregiver completes. And what we've seen over and over again is that the cognitive scores may actually be really good. And it's really the behavioral portion of the ALS-CBS is where we detect a lot of abnormalities, raising suspicion for an evolving FTD in that patient. And full-blown FTDs tends to be quite rare in the ALS clinic population, probably less than about 10%, but more subtle behavioral symptoms are common. So in terms of the diagnostic workup for ALS, oftentimes we start with an EMG. And if you get an EMG of a three spinal segment EMG is what you should order if you're suspecting ALS, if you're sending for an EMG before you send a patient to an ALS clinic. And this is sort of what a typical EMG of an ALS patient looks like. It has two components. On the left side is the active denervation component, where there are lots of fibrillations, positive sharp wave presence. And on the right side in the rectangular box, the chronic reinnervation changes, where you see motor unit potentials that are long and high, long duration and high amplitude as a mark of compensation because of the loss of motor neurons and compensation from the neighboring motor neurons that have sent sprouts and are firing many more muscle fibers than they normally do. And so there are some high-yielding muscles that are tested when you specifically request for an ALS protocol, three-segment EMG, and it's very important to specify that on an EMG request and not simply an EMG that may actually tend to sometimes miss some of these findings if you don't look at the right muscles. And so neurofilament light is emerging as a biomarker that is being used for phenoconversion of certain gene carriers if you're developing ALS or FTD. And what we know from one of the papers that's published recently, and there are several papers talking about neurofilament light in the phenoconversion stage, as well as the plateauing and peaking in terms of prognostic marker, is ALS patients tend to have higher NFL levels compared to patients who have isolated FTD. And this is from the paper from Saraceno et al. Paper in 2021. There are some diagnostic criteria that are used for research. One of them is a revised LS-Coriol criteria that was developed in 1998 that is based off of how many segments are showing combined upper and lower motor neuron signs. And the more recent one, Gold Coast criteria, upgrades this criteria and sort of fills some of the loopholes that the revised LS-Coriol criteria had missed in terms of early diagnosis of some patients who have only lower motor neuron dysfunction without hyperreflexia as such, and also incorporates investigations to exclude other disease processes rather than relying only on clinical features. And so diagnosis of ALS still predominantly relies on ruling out other mimickers. But one important workup that is sort of really changing the field in ALS is genetic testing and genetic counseling. At our center at Mass General, we're moving towards almost universal genetic testing for all patients with ALS and offering post-test counseling. And there are some sponsored panels that are of low cost or no cost to a lot of patients. That makes it more attractive also to pursue this. And obviously, you will need a genetic consent before we pursue genetic testing. And the reason also to do this is because there is one ASO that is FDA approved as a therapy for SOD1 ALS. And we also want to make sure that the patients have the opportunity to participate in clinical trials for other genetic forms of ALS as well. So, the care for ALS really falls under two buckets. One is a standard of care medication, symptom management, and then the other bucket is a multidisciplinary care. And these are the medications that are approved for ALS. And there are some articles here if anyone is interested in reading more about different review articles about ALS. And there are lots of clinical trials that are under development in various phases of testing, which is really exciting. And this is a snapshot of all the clinical trials that have targeted ALS FTD disorders, and starting from 2020 all the way to the most recent study that was launched in Canada looking at ProBio as such. With that, I will end. And thank you for your attention. This is my email if anybody has any questions you want to follow up afterwards.
Thank you, Dr. Babu. That was very informative. I learned a couple of new things, which is always exciting for me too. We're going to bring back Dr. Aldayev for the Q&A portion of this webinar. And we're going to ask a few questions and see if we can have a conversation. I think the question that is probably the most important to kind of talk about right now is, with ALS being primarily diagnosed by ALS specialists and FTD being diagnosed by behavioral neurologists, what are your thoughts on how we can improve collaborative care of those diagnosed with FTD, ALS, and improve communication between those clinics and centers?
In my opinion, I think it's always good to be aware of the other condition. So to always be looking for it, as Dr. Babu was talking about, that that the FTD or the ALS clinic at Mass General is constantly probing for evidence of cognitive or behavioral changes or changes in executive function. And we strive to do the same thing. We are constantly checking for tongue fasciculations, for reports of upper and lower motor neuron weakness, those kinds of things. So I think that's number one. And number two is knowing about your colleagues. We have the luxury of having a world-class ALS center at MGH, so we know that we can refer people to that center if we are suspicious about it. But as Dr. Babu is saying, to at least be aware of, if you don't have a center at your particular institution, to be aware of where those centers are so that you can reach out to those people the moment that you have concerns about the other condition. I
completely agree, Dr. Aldayev. And even if you are a community physician, a neurologist practicing in a smaller group practice, I would say that I know there are more and more overlap syndromes that we're recognizing in ALS and probably on the other side, and if on the dementia side as well. And I think it's important to know who our collaborators and colleagues are who are practicing in the other subspecialties within neurology, and having those colleagues sort of in our network becomes very important to even whether it is running a case by them, having them be a sounding board, or even a referral if wherever needed. So knowing who your colleagues are becomes really important to bridge the gap between the two worlds.
Yeah, thank you. I think another question that comes up a lot, and something I'm hoping we can discuss a little bit, is the issue of when somebody, the standards of care in ALS, right? And you talked a little bit about this, Dr. Babu. It can get complicated when there's behavioral variant FTD symptoms happening there. And the caregiver burden can be really, really high. So, what are your suggestions in terms of how to best approach these families when FTD ALS does exist, in terms of really maximizing quality of life, but also recognizing some of the different symptoms that are occurring and what's happening?
Oh, that's a loaded question, Esther. I think
It's very loaded.
the very first step is to really sort of acknowledge that there is a risk for developing FTD if you're caring for an individual or family with C9 or any of the other genes that could have the ALS FTD spectrum as such. And once you put this on their radar, they know what to expect. And if symptoms do evolve as the ALS progresses, sometimes FTD symptoms start later on. And I think it becomes somewhat easier to then, tie that into the multidisciplinary care component instead of treating that as a separate compartment by itself. We wouldn't necessarily change our management in any way, but we would acknowledge and we would actually bring in the caregiver healthcare proxies and be aware of what discussion to have in case we need to go to a surrogate decision-making family relative or friend in case the dementia continues in terms of goals of care and medication choices or even intervention choices, whether to do a gastrostomy and what about the decisions about tracheostomy or a non-invasive ventilation. I think these are all decisions that we'll have to make as a shared decision with the patient, caregiver, family, and if they are already established with the dementia clinic, with our dementia clinic colleagues as well. And we have the luxury of having amazing genetic counselors at our clinic that act as a bridge for both of these clinics in many ways. And if you're caring for a C9 ALS patient, and our genetic counselors have been fantastic in talking to the families about what to expect on the dementia side as well. So it's an evolving, ongoing, continuous conversation and discussion with families.
Yeah, I think it comes back to the concept of person-centered care, right? And really looking at the person, the individual family, the person, what's happening, and then addressing it accordingly based on, their wishes and desires and what the family feels they're able to do. But it's a question we get quite often, even on our AFTD helpline, from families that they're asking these questions. Well, with that said, I want to thank you both for your discussion today, for coming on. This was really informative. Hopefully it will help educate, further neurologists who are out there to make sure that they are paying attention to ALS symptoms in their FTD patients and vice versa, and making the appropriate referrals for diagnosis and care. And we will now move on to our closing.
Thank you.
Thank you. Before we wrap up, I want to point out a couple of resources that can help you and your families from AFTD. AFTD has support groups. We have a support group for caregivers of persons diagnosed with FTD ALS, specifically for those who are dealing with this diagnosis. In addition, we have 2 support groups for those with the genetic variant of FTD or ALS. We have a history of familial FTD support group. So for those who know that they have a history of C9 in their family or other genetic variant of FTD, but have chosen not to test yet for whatever reason. And then we have a group for people who have a confirmed genetic risk of FTD in addition. To learn more about either of these groups, please reach out to the AFTD helpline at 866-507-7222 or info@theaftd.org. Additionally, I would like to point everyone to the FTD Disorders Registry. The registry is a powerful tool in the movement to discover treatments and a cure for FTD. Anyone with firsthand experience with FTD, from persons diagnosed with FTD to their caregivers, family members, and friends, are encouraged to share their stories with the registry. The information you provide will help to spur innovation that will lead to effective treatments and therapies. By registering, you can also learn about opportunities to participate in groundbreaking FTD research. Visit ftdregistry.org to learn more. This concludes today's webinar. Thanks again to our presenters. I'd also like to thank Rush University for allowing us to offer CECs and CMEs for this webinar. Be sure to check your email tomorrow for information on applying for these credits. If you have any additional questions or comments about today's presentation, please reach out to us. We would love to hear from you. Thank you.